was fantastic. Some really thought-provoking points there. I'd like to call up the panel, panel 10, the role of academia in global surgery. If I could have the next slide, please. And I'll introduce our next moderator, Mark Shrime. So Mark is an otolaryngologist by training who then did 2 fellowships, one in head and neck cancer and one in head and neck cancer reconstruction, but then didn't stop and got an MPH, and then didn't stop and just sat for just defended his PhD, so he just recently successfully defended that. And he's going to be coming on to the program in global surgery now as our head of research, so he's great to have him. He was one of the modelers for the Lancet Commission and really did a tremendous job. So the next slide, please. There we go. Maybe the next one. And the next one. All right. And the very next one. Perfect. Now we're up to speed. All right. Justine, you've already seen this slide before, so she's the editor-in-chief of Lancet Diabetes and Endocrinology and was one of the driving forces for the commission and the reason that we actually were able to do this. Charlie Mock, he is a professor of surgery, epidemiology, and global health at the University of Washington. Holds an MD, an MPH, and a PhD. That seems to be a trend on our panel. And we all know the tremendous work that he's done with DCP3, and I was just thanking him, and I've also said this to Haile DeBas. They were so wonderful and so collaborative with DCP3. It was actually a role model for us in terms of how we should run the commission, so I thank both of you. Matchecane Cossa, he's a general practitioner, began work as a general practitioner in rural Mozambique, subsequently trained in thoracic surgery. He's a member of the Cardiovascular and Thoracic Surgery College, also a co-investigator in MEPI in the Medical Education Partnership, and he's now the director of the National Program in Surgery at the Mozambique Ministry of Health. Sergelen Orgoi is from Mongolia. She trained in a number of different places in Switzerland, Finland, Korea, and in the US, and she's now the vice president of the Mongolian Surgical Association, leads liver transplantation team there, and is the head of the Department of Surgery at her university since 2002. So I'd like to call the panelists up here, and I will turn the baton over to Mark.
So I have a bit of a problem, and that is that the neglected stepchild analogy has been taken, and the invisible friend has been taken. But really, we saw from what Josh said earlier in the morning, and we saw from what was just said right now, that possibly research, global surgery research, might be the imaginary friend of these two. And so that's kind of what I want to address with the panel here. I'm going to stop talking and actually just ask questions to the panel like we've done before. I'll ask questions to each of the panel, and then we'll have the floor open, and then we'll have about 5 minutes for them to respond. And let me start with Justine. So Justine, as an editor of a journal, what do you think the sort of ethical, financial, and academic responsibilities, that's the word. What are the responsibilities that you think you have as a journal editor for publishing global surgery research?
Okay, thanks, Mark. I will address each of those in turn, but there are substantial overlaps, I think, between the ethical, financial, and academic responsibilities. I mean, the first thing, so I'll get out of the way, is financial. I mean, firstly, yeah, okay, I work for an evil publishing house, and it is on the stock market, say of it what you will. So the publishing house has a duty to its shareholders. The editors, however, like to distance themselves from that, and we have absolutely no financial obligation at all when we consider which papers to publish. So that doesn't come into our consideration. If you're wanting to talk about open access versus reader pays, that's a whole different ballpark. I think somebody in Nature did some research once, and they showed that to publish one paper costs tens of thousands of dollars. So somebody somewhere, as Jeff Drazen has said to me recently, has to pay. So if you want good, high-quality papers, somebody somewhere has to pay. Who that is, I think that's a matter of debate. The one thing I would say with global surgery research, as in any global health research, is authors from lower middle-income countries shouldn't have to shoulder the burden of paying for publication. That's one thing I will say. When we're coming to the ethics, well, you've got the generalities of ethics, of course, which we all know about and I won't go into. But another thing is the whole idea of research waste. Lancet recently did a series on this, and it applies to global surgery as well as everything else, is that out of about 2,000 research publications 20 years ago, about 4 of them were any use later on. So I think that an ethical responsibility of a journal editor also crosses into the academic responsibilities, in that we should get out there and we should educate people. So again, it's this going fishing with people, yeah? So we should get out there and we should educate people, but really we are the end users. So most of the time, by the time somebody has sent their research into us and you looked at it and you go, okay, this is great, you've done this massive research study, now what was your hypothesis? Which is what I get all of the time, and I'm sure you do too, Charlie. Then it's too late. So we have, I would say, an ethical and an academic responsibility to get out there and teach people about how to do research. It is what we are experts in. I mean, and as Richard has just said, with surgery research, we're at Research 101 here. I mean, this is... I broke my talus and calcaneus recently, and I said to the orthopedic surgeon, what do I do? And he went, I don't know. He said, you can do this, this, and this. And I went, well, is there any evidence? No. And I was coming back, being driven back on BBC Radio 4. There was an orthopedic surgeon talking, and he said, addressing this question, and we're going to do this thing called a randomized controlled trial. And he sounded absolutely blown away with the concept. But we need to get out there and tell people. I broke my arm recently. Again, I was offered 3 different treatments. I went away and looked up, are there any randomized controlled trials for displaced mid-shaft humeral fracture? No. Nothing at all. So not only do funders need to provide money, we need to start talking to people, say, hey, you guys, you need to do the research. But on the other hand, not all research is publishable, and not all research should be published, but we need to encourage health systems research, which isn't as obviously publishable as other sorts of research. So, one of the ways that we can do this is if you want to do audits, looking at perioperative mortality in your hospital, for example, and you are the person that collects the data, when people from high-income countries come in and hijack that data, those people that actually collected the data should be listed as authors. And we have an ethical responsibility to make sure that everybody has contributed to the research actually is listed as an author. So I'm aware that you're on a time budget. I could speak all day about this, but I will give everybody else a chance.
Thank you. I actually want to play off on that. And Matchecane, as coming up in Mozambique, what do you think the primary barriers that you faced were to actually perform surgery? Those are other barriers, to perform research, high-quality research, and to get that research published.
Okay, thank you very much. First of all, as you said before, as was presented before, my country, for example, has very few surgeons, less than 33 surgeons for the country, 25 million people right now. So we have a lot of work to do. So to divide this time of attending patients and doing research is very little time. That's the first thing I would say. And the second thing is the money constraints. People are as we don't have very much good income, people tend to go to the private sector to compensate their time for incomes. At the end of the day, there's no time for doing research because people are looking for money to survive. So there's two basic things. First of all, time. Second is the constraints of better salaries. So people don't do research in surgery in Mozambique.
And do you think that, this is more sort of a broader question, do you think then that focusing on research in settings in which clinical delivery is itself difficult is something we should not be doing? Should we be focusing on clinical delivery primarily then?
That has happened in Mozambique for all the years since the independence. All the surgeons have always focused only on attending patients. Right now, things are trying to change with younger surgeons, but never, with 25 surgeons for all the country, it wasn't possible for them to have time for research. And it wouldn't be fair to expect them to do research instead of seeing patients.
Thank you. Moving on, Dr. Orgoi. What have you found in terms of barriers that you've seen in your career with collaboration between high-income countries and low and middle-income countries? And specifically, what is it that you look for when you're looking for collaborators? What characteristics do you look for?
Thank you for the question. And now in this time, between researchers who lives in high-income country and in low-income countries, same, because in this time we have good connection, internet, and we have a possibility to send all of our research work to our friends. But we have some difficulties. First, in low and middle-income country, researchers have some financial difficulties. And it's connected for publish our articles and all of research work. We have some financial difficulties. Second one is language difficulties. Because in middle-income and low-income countries, researchers studied English, but not in high level, like in published research work. And for that, we need collaborate with researchers who knows English well. For example, in Mongolia, we have many researchers know English well, but their language knowledge not like in who speak English well. And for that, always we collaborate with researchers. We send our data to our friends. And third one is for surgeons. Surgeons is always lazy to do research. And always they want to stay in the operating theater and they want to operate, not write, not to do research. This one is big problem for Mongolian surgeons too. And we ask from our young surgeons always to do some research work, but sometimes we haven't good results. And next, our difficulties, our statistics knowledge is low than the other doctors. Also, surgeons don't want to do research, and their statistics, they don't know what is the main research work and how they do and like that. And for improve, without research, impossible to develop surgery. And for that, we need to train our young surgeons for research work, not just only operation. This is my opinion.
Thank you. Professor Mock, so we heard before lunch in the trainee section, there was a lot of questions about research there. So in your experience, what advice would you give to young surgeons and young trainees who want to do global surgery research, and what were your biggest barriers in doing it?
Thank you. So first about the barriers, several. Well, in general terms, affecting pretty much anyone working in this field has been the lack of understanding of its importance, that is the importance of global issues in the world of academic surgery, especially here in the US. and correspondingly the lack of understanding of the importance of surgery by global public health. I think both are changing, and this commission has been a important step in that. Also, many people talk about a lack of funding. That's definitely a barrier, but I don't consider that a big barrier, and I'll refer to a bit more about that in just a minute. But I think a lot can be done with small amounts or with no funding. I'd say the biggest barrier has been myself, and that's my own lack of understanding of the realities of providing surgical care in low and middle income countries, and hence what's practical to strengthen such care. I did spend 4 years working as a surgeon in Ghana and West Africa, but ultimately it's hard for an outsider to fully understand local realities. And that's why I put a big premium on working collaboratively with people who are indeed spending their careers working in their own countries, which leads to your next question about advice. And my biggest piece of advice, which I try occasionally to follow myself, is total respect for your collaborators in low and middle income countries. As we've heard, too much of the time, foreigners parachute in, gather data, and leave. Working collaboratively often means putting the interest of your collaborators ahead of your own, and doing that is certainly not best for your own career most of the time. So giving total respect to your collaborators includes deferring to others on the ideas that you'll work on together, and often pushing the limits of what constitutes first authorship, and deferring as much as possible to local collaborators on that. And if you do get research money, steering as much of that as possible to your partners and to the work on the ground. By the way, I do try to practice what I preach, but I'll admit I do so imperfectly on all of those. In terms of ideas to work on, in global surgery, mostly we're talking about strengthening service delivery, less often, occasionally, but less often about basic biologic principles. And in terms of strengthening service delivery, it's often hard for outsiders to have ideas on what will be practical and affordable and sustainable, especially in the long run. These ideas need to be developed collaboratively, and this implies being willing to work with others on things that they think are priorities, even if you think they're not the most publishable thing for the moment. And then in terms of funding, I think there are some deans and chairs here in the audience, and I'm sure they don't want me to give this advice to their junior faculty, but money is not everything. And for much of surgical care, we're looking at ways to improve the functioning of systems that are already there and are already financing themselves. And outside money may or may not help with that work. When I look back on my own past 25 years, I've done a lot of things that have been pretty minimally funded or not funded at all. I've also, I think, been fairly successful in getting grants, especially in the last 10 years. And I think if I've done anything meaningful, it's unrelated to the funding. Things that I did earlier on with minimal funding, I think, are equally meaningful to what I've done with more money. So, I mean, definitely money is useful. I'm not a nihilist, but and I've heard people talking about the idea of a global fund for surgery. That would certainly be useful, but I don't think we need to sit back and just keep moaning because of lack of funding. There's a lot that can be done without it.
Thank you.
Thank you.
So we have about 4 minutes to take questions from the audience, so please tell me who you are and ask the question.
Good afternoon. I'm Robert Riviello at Brigham Women's Hospital. I have a question about engaging our colleagues and partners in whatever low-income setting. We've heard talk about overwork and hard to get good science out of surgeons. Early in the day, we heard talk about hard to get surgeons and anesthetists, obstetricians to train. And I wonder what kind of strategies that there are to incentivize docs, academics in low-income settings to be able to do the academic work, be it the training, be it the research, when they're already pulled in the clinical direction, in the administrative direction, when they don't have administrative staff, when they don't have research staff. Imperfectly in high-income settings, we have figured out ways to do that, whether it be by grants, by outside funding, by industry. But I don't know that we have financing mechanisms or incentivizing mechanisms to help our colleagues do the kind of work that we're talking about today. Thoughts?
There's a question back there. Yes.
Hi, Neerja from Johns Hopkins, but trained in India. So there's obviously a number of issues with people getting involved in doing surgical research in low and middle income countries, but one of the issues that I face and a lot of my friends face is the cost of journal subscription and how most of our universities back home, they don't subscribe to all journals. We have no access. We cannot be part of the conversation when some paper comes out. Are there initiatives to provide journals for low cost, and if there is, what are they, and are they being advertised?
Thank you.
Just a question to, I guess, everybody, but one of the barriers, and I think Dr. Mock, you addressed this, is there's this need amongst high-income country researchers, especially folks who are involved in this work, like myself, who are young in our careers, to be first author, to be second author, and that disincentivizes or puts at odds the more magnanimous approach, which would be to really advance the careers or get other folks interested in research in terms of collaborators in low resource settings. Do you see a role for the academic community in high-income countries to reassess the way global health papers and research generated in these settings are evaluated? So when it comes for time to promotion or other sorts of things that matter to young researchers, that the second author paper is probably more important in the appropriate context.
Before I turn it over to you guys, I want to throw a little monkey wrench or spanner into the works. With all the barriers that everyone's talked about finances, Justine specifically, I wonder if you could address the open access model, because that does increase the barrier to the author themselves. So I'll open it up to you guys.
Sure. Okay, so firstly, open access is not the only way of getting papers to where they need to be read. And don't forget that open access, I've already said, somebody somewhere has to pay. It's like fame, yeah? And either the author pays or the reader pays. Somebody somewhere has to. So open access is not going to solve the world's problems when it comes to publication. But you can. What we do is we try to get local language versions. So the Commission report, I hope, will be translated. Various other things from the Commission are being translated into different languages. So that's the first thing to help overcome the language barrier. The second thing is, and I think journals should have a duty to do this, an ethical duty to make global health research publicly available freely, because we know that people in lower middle income countries cannot afford it. I was the web editor of the Lancet for a while, and I snuck something through the system. Hopefully nobody from Elsevier is listening to this, whereby we have a geo-IP system. So basically, if you log on to the Lancet.com from one of the lowest development index countries, there's 42 of them, you'll get immediate free access to everything. So we do, and journals should do this sort of thing, is allow people to access where they are, where that research is needed. So that's not open access. We're not an open access journal.
No, for publish our research, we have open access and we have possibility to publish in World Surgery Journal or all of other journals in high impact factor. But sometimes we have some difficulties for collect data in, for example, in my country. Because in high-income countries have good set of collect data, but in middle-income countries, sometimes we have difficulties collect data. Our Dr. Price know about that well. We publish our laparoscopic surgery training article. For collect this data, we worked for 2 years, because sometimes we couldn't find some data from some provinces. Like in that, we have difficulties, but this is this side we have possibility to improve our statistics and data collection in low and middle income countries. In that time, we have possibility to publish our articles in journals.
What I could comment is that lately we have access to open access articles through Inari and etc. But the thing is, most of the young surgeons and young surgeons don't have the culture of working on research. Now we have like a small computer lab, okay? But when you look at the statistics, that room is most of the times empty, okay? And most of the people don't have hand devices to do the research, so we know for sure they're not accessing that. But talking with some of the United States colleagues that goes to Mozambique, I understood that here during their training for surgery, they have one year free for doing research. But in our training, we don't have that. So everything is focused on treating patients and seeing patients. So at the time we want to understand why people are not doing research, we have to take into account this kind of things, that we don't have the training to do research, and we've never been asked, and nobody has ever, during our training, said that research is important. Said what's important for you is to treat patients, because you're so few. If you look to pediatricians, to internal medicine, they do little research, because their training is a little bit focused on that. But our surgeons' training in Mozambique, it's not. That's one of the main reasons too.
In Mongolia, for surgery training, for residency training, they haven't any research training. Just we teach them how to do surgery and how to treat patients. And just in doctors and master degrees training time, they have time to do research. And we think that now we need to include in residency training also research time.
Charlie, did you have any last words?
Just one take-home message. We're asked to wrap up with a take-home message, and this is for journals and professional societies, and in part this is to myself, since I'm an associate editor and also belong to several professional societies and also judge abstracts. And so in deciding on articles or abstracts to accept, or for professional societies that give out grants, I would put more emphasis on the significance of the work. Not that they don't already, but I think there's been a definite bent against global surgery as not as rigorous as the articles that are obtained from domestic sources. In my opinion, the significance of an article or an abstract or a proposal about global surgery is inherently 10 times more significant than an equal piece from the high-income country, because it deals with 10 times as many people. That is, it puts, it deals with the circumstances of that vast majority of the human race who live in poverty in low and middle income countries, and hence the vast majority of surgical patients. And I often see that articles or abstracts get rejected or prioritized lower because they're not considered as methodologically rigorous or as well presented as similar pieces from high income countries. And these considerations are, of course, of importance, but I would just make a plea to those who judge these articles as reviewers, as editors, including myself, that the significance of the work in terms of the number of people with surgical diseases who are addressed also needs to be considered as an important factor. So thank you.
So thank you to the panelists. So John has asked that we not take a break, so I'm going to invite Andy Leather up to do the next panel.